start of this webinar, I would like to just remind you about us as a group. We had the vision of that we want all women in Oman to receive the standard of care in gynecologic surgery and fertility management. And I just want to tell you about what have we done from the time that we have been established before we start our tonight activity, because I feel I am obliged to update the members of the Oman Society of Obstetric and Gynecology about the group and its activity. And of course, our activity is the time where I have the opportunity to share such a thing. We started with a project out of all the activities that we, or the objectives that we have, which are about 10 of them. We chose to go a simple thing like having a laparoscopy for all Omani women who need surgical intervention for tubal ectopic pregnancy in Oman, anywhere, anytime, which is, it's a big challenge, and it is one of the established standard of care across the world nowadays. In order to do that, we had some activities where we tried to gather information about the subject that we are tackling, where we had a survey to all the head of departments of obstetric and gynecology in Oman in the government sector. We had we shared, it was an opportunity to share with them what are the challenges that they are facing, and to prioritize their those challenges and brainstorm some of the solutions. We had to gather some national statistics regarding ectopic pregnancy, its management, what is happening in the country. And then those information that we had, we shared it, some of it at least, with the members of the society through a webinar that was arranged in November of last year. And then we issued a report to the Ministry of Health, Director General of the Specialized Care. And after that, we sought help to try and actually start practical aspects of this big challenge. We tried to raise funds to have equipment enough to train people for laparoscopy, and alhamdulillah, in collaboration with the WHO Oman office, the American Embassy, and some other NGOs and private sector, we now own our own laparoscopic simulators, through which we are going to try and do some laparoscopic workshops also. We have a very promising collaboration with the Ministry of Health, where we already have a collaboration with the Department of Women and Child Health, Dr. Jamila Al-Abri and her team. We had a successful and promising meeting with the Assistant Director of the Specialized Healthcare in Oman, Dr. Adil Al-Ansari. There were some promising encouragement, and also we have the support and a meeting with the Director General of Quality in Healthcare. With the support of all these institutions, inshallah, we are hoping that we are gonna have some official collaboration in a term of a signed memorandum with the of understanding with the Ministry of Health. We have an approved approval of an OMSP for a CME program, where we are going to share some articles within the group of the Oman Fertility and Gynae Endoscopy group to gain some CME points. We are starting our first laparoscopic workshop in October 14th, inshallah, and I think everybody have seen the brochure of the activity. Our intermediate laparoscopy skills workshop is going to be on November 21st, inshallah, and we are going to have a scientific endometriosis activity on the March 1st, and everybody knows that, inshallah, March is the endometriosis month. What we have done in laparoscopy, we are trying to implement it on the fertility aspects of it. And this webinar, inshallah ta'ala, will be the first of such, where we have gathered some information. This webinar is part of gathering information and disseminating knowledge. We are going to share whatever we have and whatever we gather out of the webinar tonight. And we are going to try and brainstorm some of the challenges that we are having. And then we are gonna bring it up to the private sector, because the private sector is the one that is tackling most of the advanced fertility management. And we are hoping we are gonna get collaboration from everybody on this project. So this is what we are gonna do and work on, inshallah ta'ala, for the coming few months that I wanted to share with you. Now this brings us to tonight's activity, and with no delays, I would like actually to welcome Dr. Badriya Al-Fahdi, who is the president of the Oman Society, Society for Obstetric and Gynecology. And I'm actually very happy to have her on board. She's a very busy lady, but because I would like her to say a few words for us in this evening. And Dr. Badriya, you are most welcome.
Thank you, Dr. Mariam. Thank you very much for introducing me. And I would like to introduce, or to thank actually, the Oman Fertility Group and Endoscopy and Gynae Endoscopy Group for the first event after the new board, under the umbrella of the new board. I wish you very successful webinar today. And I wish all the groups, including our fetal medicine group, to be as active as your group. And I can see actually your activities, even despite the pandemic of the COVID-19 pandemic, you have not stopped, and you have been running behind the laparoscopy simulator. I could see how much you have been running behind. I try to help as much as I can. I wish you a successful event today, and thank you very much for all your efforts.
Thank you very much.
And I would like to also welcome all the speakers.
Thank you very much. Thank you. We wish you a pleasant evening, inshallah.
Inshallah, thank you.
Inshallah, thank you. As you see in the brochure of this activity, we have very expert people, and I actually would like to thank the fertility specialist or those who have the primary interest in fertility as members of the Oman Fertility and Gynae Endoscopy Group, Dr. Rahma, Dr. Naama, Dr. Khalsa Al-Hattali, and all the team who worked hardly with her, also including Dr. Mona Al-Badi, for arranging this webinar and bringing some hot subjects for discussion. As you see in our schedule, our first speaker is Dr. Francisco Ruiz. I actually, as a fertility specialist, Dr. Francisco have been, one of his highlights actually is the collaboration that he established with many of the institutions in the government and also in the private sector. Dr. Francisco has a master's degree in fertility, and he have been working with the IVI clinic for so many years and in different countries, including Mexico and Spain. And as far as I know, we have been in Oman in the IVI clinic since its opening and establishment in 2017. During these years, I think he accumulated some special experience with infertility issues in Oman, specifically in Omani population, because we understand we have some special challenges as a population. And part of his experience is dealing with male fertility, which is a subject that the gynecologists are not always discussing openly. And I'm very appreciative for him bringing up such a hot subject for discussion and knowledge tonight. He will be talking to us about male infertility, their experience over 4 years in Oman. Dr. Francisco, you are most welcome.
Thank you very much, Dr. Mariam, for the kind introduction, and thank you for the invitation as well. Thank you, Dr. Rahman. Thank you, Dr. Badriya. And not just to congratulate you as well for all the work that you are doing. It's really impressive. And just give me 1 minute here for so I will start sharing here. So I hope you can see the slides here. And so what we wanted to talk today was just the experience that we've had since we started here in Muscat, in Oman. So as you may know, we started in 2017 as IBI Group, a Spanish group. And then now we are a standalone group. It's called ART, Fertility Clinics, under the direction of Dr. Fatim in Abu Dhabi. And these 4 years we have learned and we have seen many patients regarding male infertility. So it has given us certain knowledge, and I think it's important that we share what we have seen. So this is just the overview of the lecture that we will have today. It's the definition of male infertility. Then we will talk a bit about, is it really a male factor when we see a patient? Just a correct analysis or interpretation of the semen analysis. Then also we'll talk about the focus on genetics when we talk about male infertility, which is one of the main points of the lecture. And also we will share with you the results that we have from the testicular biopsies that we have done in our center since we started. So for the first one, the definition of male infertility, we all know that is the inability to achieve a pregnancy when a couple is at least trying for 1 year. And also part of the definition is an abnormal semen analysis. So this is very, very important, because the correct interpretation of the semen analysis will tell us if we're dealing with a possible male infertility or not, or a male factor. Actually, ASRM and ESHRE, the American and the European Society of Reproductions, have included abnormal semen parameters in their definition of male infertility. So that's why it's a very, very important condition that we know how to interpret this semen analysis. I cannot stress that enough. How do we interpret a semen analysis? Well, we do it based on the WHO. They publish a manual that they more or less have guidelines, and they show us how to correctly follow the evaluation, and then we can more or less know if there could be a male factor. No? But it has to be also, even though it's relatively easy to see in the microscope, but it has to be done by trained personnel. So this is also something that it is a responsibility of the center or the hospital that is doing the semen analysis, that we need trained people, even though it is relatively easy, but we need trained people that know how to do it. And usually we have one abnormal test when we usually prefer to repeat it, at least to have two. And the most important aspects of the semen analysis are 3 of them. The sperm concentration, that we usually want to see at least 16 million in each ml. Then the progressive motility, this is the sperm that move forward. So we want to see at least 1/3 of the sample, which is 30%. And also the normal forms, the shape of the sperm, which is around 4%. For the most important ones, I would say it is the sperm concentration and the motility. And this is from the last published manual, which was published this summer in 2021. And I wanted to talk about this because in our consultation, sometimes we see patients that have been going with many, many doctors, male patients. So they come and they tell them it's a male factor. They go here, they do another test. So they are very, very confused. And when we see them in consultation, it doesn't seem to be at all a male factor. So this is why we wanted to talk about this. We wanted to include this point today. The latest manual of the WHO, it gathers information about normal semen analysis from more than 3,500 subjects. So it's a good number, but it's not a lot of people. But the most important point is that it gathers information from fertile population. So these numbers that we use to say if a person can be fertile or not comes only from a fertile population. This is very important to always keep in mind. It is true that it comes from 12 countries and 5 continents, but it is not something representative of the whole world. So maybe certain regions in the world could be different than this. So there are certain limitations, no? And we cannot say, okay, if a person has less than 16 million sperm per ml, then this person cannot become pregnant. No, this is not true, no? Because sometimes we see patients even with a very low number that they have had spontaneous pregnancies. So these are very important points to keep in mind. And here you can see, you can even go to the WHO, you can download the data set of these patients. And you can see here that even the first percentile number 1, it is 7 million per ml. So this is people that have become pregnant even with a very low number of sperm. So as I said before, we cannot make just a cutoff point. No, that sometimes we see patients with 15 million and we tell them sorry, but you cannot become pregnant because it's 15. So they are really worried, they are confused, and in the end, it's not really a male factor. No? So the semen analysis just guides us towards a possible male factor, but we cannot do a like a cutoff point, no? Unless it is on the extreme. Of course, if we don't see any sperm, then most likely that is the reason. Here from the previous marathon in 2010, you can see the concentration of the sperm. So it is very dynamic. It varies. Sometimes it goes up, sometimes it goes down. So it is very, very dynamic. So that's why we see one semen analysis that it is normal. We don't usually repeat it because most likely that is the case. But if we see one abnormal, either the concentration is low or the motility is low, then we always prefer to do a second test to confirm because of these changes. No, it could be completely normal. No, maybe the patient had a fever before 2 months ago, so this could have an impact. But the sperm could be completely normal. And this is something that we used to see very often, no? That the patient came for first consultation and then we saw a stack of semen analysis. Sometimes we saw at least 30, 35 semen analysis being done. So most likely the patient doesn't need to do that many. So either 2 or 3 are relatively what we need to do. No, it can improve accuracy, and we can more or less know if it's really a male factor or not. So we don't really need to be testing every single month for 20, 30 times. 2 or 3 tests are more than enough most of the time. And also it's very, very important to consider the female factors as well. We always have to see the couple, always, not only the male or the female patient. Because sometimes we have seen patients that have been going with doctor to doctor, thinking it's a male factor, and then we see the semen analysis close to normal. Sometimes they have even had a spontaneous pregnancy, meaning that the sperm most likely is not the reason. And then when we see the female patient or the wife, we see a problem in the ovarian reserve or PC or some other condition. So it's very, very important to see the couple together. Because sometimes we just focus on the sperm and maybe the issue is on the other side. Sometimes, of course, it can be together, but it is very important to see the couple. Then we also wanted to focus on genetics because this appears to be the most common reason here in Oman for male infertility. We know that there's several causes. No, it could be problems due to chromosomes, systemic conditions, infections, surgeries. But at least from our experience in Oman, we think that genetics is involved in many of the cases, no, especially when there is a very low number, severe oligospermia, or no sperm at all in azoospermia. So usually this is related to genetics most of the time. It is true that in Oman, we see patients that smoke. Obesity is also an issue, but these are factors that it is really difficult to quantify how much of an impact they are having on the quality of the sperm. But the most important aspect is genetics. No? And this, of course, we always try to back up our claims. No? So if we compare in different parts of the world, a male factor, how common it is, it appears that in the Middle East, it's slightly a little bit higher. No? The prevalence is around 60 to 70%. So the question is, why is it more common in the Middle East, a male factor? No? Is it the way we live or the way we eat? But we think it is related to genetics, no? And we think it's related to consanguinity. We know that consanguinity can have an impact on certain genes coming together, no? in the children. In Oman, according to Sultan Qaboos University, the rate of marriage between the family is around 49%, and it is likely to remain high. In our clinic, we always ask the question to the patients if their parents are related as well, because we know that when there's parental consanguinity, it has been reported that there can be an impact not only on the number of eggs for women, a lower ovarian reserve, but also for men. There appears to be an impact on the number of sperm and the sperm production. And in our clinic, we see only around 25% parental consanguinity. That means that every male patient that comes, 25% of them, their parents will be related. And this is important because we have seen that from every 10 patients that come to the clinic, we see that with parental consanguinity, we see that 2 of them will present with azoospermia. Or if we see it the other way around, from every 10 patients that come to our clinic that have been diagnosed already with azoospermia, in 4 of them, they will have parental consanguinity. So even though it's not causal, this relationship, but we know there is something there, that genetics is involved. And lately, in the last 2 or 3 years, there has been several publications and from patients in the Middle East that have discovered certain genes and behaving as single gene disorders, and especially in genes that are related to meiosis. So if a person carries these 2 genes, then they can have a problem in the sperm production, in the meiosis, in the spermatogenesis, and even some genes that can be related to women and to men as well. So this is key, and this is one of the things that we need to push also in Oman, that maybe we could try to comprehend or to know what are the genes responsible for azoospermia in the Omani population, which we don't really know yet. We are also trying to be active in research. We know that ethnic and sociocultural differences can be related to infertility, and this is what we have to continue in studying. And we also wanted to show you the results that we have from our clinic since we started in 2017. We wanted to talk about this because the most challenging part in male infertility is non-obstructive azoospermia. That means when there's a problem in sperm production. So the patients have to go to a surgery, and then we try to find if there is a sperm or not. It is important to mention that in our clinic, we don't have the microscope. We don't do micro-TC, we do regular TC as well. We offer this in our clinic in Abu Dhabi, but not in our center in Muscat. But since we started in 2017, we have done a total of 63 procedures, 63 testicular biopsies. From these, 56 are individual patients, and the other number is because they have repeated maybe a second or third time. So in total, it has been 56 male patients that have gone through TC since 2017. From these, the 56, 37 patients we didn't find sperm, and 19 patients we did find sperm. So our sperm retrieval rate per patient is around 33%. So that means that from every 10 patients that come to our clinic with non-obstructive azoospermia that we have to do surgery to try to retrieve sperm, maybe 3 out of 10 we will be able to find, which also goes more or less in line with other publications. It goes from 30 to 40%. Some centers in the world say 50%, but they select the patients as well. But overall, it is 33%. From this, from 19 patients that we found sperm, 2 of them, they haven't used the sperm, they just froze the sperm. And in 17 patients, we transferred embryos, and in 5 of them, we had a pregnancy. In 4 of them, we transferred embryos. In these 17, we transferred 4 patients, but we didn't achieve a pregnancy. And the rest, even though we had embryos, but at the end, we didn't have any blastocysts to transfer. So the same, from the patients that we were able to find the sperm, only 30% of them were able to achieve a pregnancy. So this is challenging. This is a challenging situation. So this is something that we have to push and understand the causes and maybe try to overcome this. And for the causes of non-obstructive azoospermia that we have seen, Klinefelter doesn't seem to be that common. We have seen less than 10 patients with Klinefelter. YQ microdeletions, in these 4 years, we have seen 1 case of complete deletion. In this patient, we didn't do any surgery because the chance of finding sperm is practically none. And 2 cases of partial C deletion. Only 1 of them underwent a sperm biopsy, a testicular biopsy. But unfortunately, we didn't find sperm in this patient. But most of the time, when we do the YQ microdeletions and the karyotype, we don't see a cause of the non-obstructive azoospermia. So we cannot tell the patient exactly what is the issue, but most likely it is related to genetics, as we have seen, and most likely behaving as single gene disorders in genes related to meiosis in spermatogenesis. And we just wanted to give you these 3 messages. I think these are the most important according to our experience, that we have seen an overdiagnosis of male factor with the semen analysis. We see many patients that have been told that the problem is the sperm, when sometimes they have had spontaneous pregnancies, and when we see clearly that the problem could be in the ovarian reserve or any other female factor. So this is to keep it in mind, and not to order many semen analysis. 2 or 3 most likely is enough. Then also to consider genetics in the role of severe oligospermia when the concentration or the number of the sperm is very low, and in non-obstructive azoospermia, most likely is related to genetics. But yes, of course, we always ask for a karyotype and YQ microdeletions. And it continues to be a challenging situation, the non-obstructive azoospermia. We only find sperm in 33% of the patients. And from these, the ones that we find, only 30% were able to achieve a pregnancy. So it's very, very challenging because we don't have any other options for treatment. And with this, I conclude, and I thank you very, very much for the opportunity to speak. And thank you.
Thank you very much, Dr. Francisco. I'm very the slides and the information that you delivered, actually, it does reinforce some of the information that we already have been hearing. And it's very good to share numbers, because we always hear that Omanis have lots of genetic disorders. How much does it impact fertility? I think it is just an area that we started to tap. And thank you for sharing the information from your center. I would, so thanks a lot. And I would like to remind our participants that the chat box is open for you to post your questions, and inshallah we will keep the questions till the end of the webinar, where we will prioritize some of the questions and ask the corresponding speaker for the subject. And also I would like to remind everybody that we are live on the YouTube channel of the Oman Society and Obstetric, the Oman Society for Obstetric and Gynecology. So whoever have an issue logging in on the actual Zoom, then they can follow us on YouTube. And with no further ado, I would like to invite our next speaker. I actually have not, when it comes to talking about Dr. Muna Al-Badi, I feel that I like to say only few words. She is, mashallah, one of the fertility icons in Oman. Dr. Muna Al-Badi have been actually a classmate and a friend, and we are from the same area in Oman. So, you know, kind of beside the professional relationship that we share in terms of the specialty in the obstetric and gynecology, she carried the burden of establishing laparoscopic surgery in Al-Dhahira region with the support of the team in Abri Hospital, including Dr. Fatma Al-Abri. I would also, and I think everybody knows her as a fertility person, and just remind, I'm trying to remind people that she had a residency program in OB-GYN, and she had a fellowship in fertility from Singapore, and she had been mainly focusing on laparoscopy and fertility management, and for tonight, she actually chose a subject that I think lots of our colleagues gives a priority to, because it touches the women and our patients on daily basis. She's going to talk to us about age and lifestyle with fertility, reproductive facts. And Dr. Muna, you are most welcome to share some and shed lights on these issues that we see with our patients.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا ما دكتورة مريم على nice introduction. Thank you very much. As Dr. Mariam has introduced my presentation, it will be touching two variables affects the fertility ladies either in Oman or worldwide. I hope by the end of the talk of my presentation, we can find a solution for those two variables. How can we improve it in order to help couples in Oman in their subfertility management? So as Dr. Mariam mentioned, that I will have a touch on the two variables, age and lifestyle, related to fertility. When I should think of pregnancy, as you know that many women are planning of pregnancy in a time when they are biologically less fertile, and this because of the older age of maternity at that time. And as you know that there is a biological clock for all the ladies, all the women are born with all eggs they will ever have and use. There is a social trend in women worldwide shows a tendency for postponing their pregnancy until later years of reproduction. All of this may be due to building up of a career in a woman, late marriages, increased divorce, remarriage, or some other reasons. As you see here in the slide, there is a myth telling women can have children at any age because many women have babies in their 40s. But the fact telling, no, the age is the most important factor affecting the woman's chance of conceiving and having a healthy child. Many women in their late 30s and early to mid 40s give birth to healthy babies, but many in these age groups are not able to have a baby. Myth telling IVF is a good backup option for having a baby later in life, but the fact both naturally or with IVF conception, the pregnancy becomes more difficult with age. Reproductive facts that everybody has known in the medical field that the female fetus born with the female fetus, since she is in utero at 20 weeks, will have 6 to 7 millions of oocytes. But at birth, those 6 to 7 millions will drop down to 1 to 2 million oocytes. And at puberty, it will reach with 300,000 to 500,000 out of all the previous millions. And this is due to the programmed apoptotic physiological process in the body. This process will continue until menopause, when only a few hundreds left over later on. As you see here, that at birth 2 million, then at puberty it will drop to 400,000. Later on throughout her ages, she will have few hundred thousands and landing up with 0 oocytes after age of 55 years old. So the age has a big magnitude on fertility. For healthy couples in their 20s or early 30s, the chance that a woman will become pregnant is about 25 to 30% in any single menstrual cycle. This percentage starts to decline in a woman early 30s. It declines more rapidly after age of 37. By age of 40, a woman's chance of getting pregnant drops to less than 10% per menstrual cycle. A man's fertility also declines as well as the woman, but it is in a less predictable manner. So if you will see, there is a big drop in the percentage, thought that within 10 years age only, from 30% to less than 10% after age of 40. The age will affect the fertility in different ways. It will affect the quality of the eggs. It will affect the number of the eggs by getting less number, and also increase the number of miscarriages rates if the pregnancy happen at older maternal age. If you will see this graph, there is a paradoxical relation between the maternal age, advanced maternal age, and the fertility rate. As the maternal age advancing more, there is a drop in the fertility rate and increase in the spontaneous abortion rate. And this is, as I mentioned, because of the quality of the oocytes or genetic defects in the sperms or the age after the age of 40. It is a good idea to talk about your plan once a year with your OB/GYN doctor. Ask yourself whether you would like to have children in the next year or not. If the answer is yes, you should go ahead with the steps for a healthy pregnancy. But if the answer is no, you can make sure that you are using a reliable birth control method after discussing with your doctor. Sometimes it might not be enough time to decide about birth spacing as well. So all the women should think about whether they would like to have a child or not. And this is called reproductive life plan. If you would like to have a child, you have to have a simple statement like, I would like to finish school and have more money saved before having a children, or I would like to have children in my 20s when my chance for a healthy pregnancy are best. Talking with your OB/GYN doctor will help you to develop your reproductive life plan and what is the next step to take an action. Experts recommend fertility evaluation for any couple who got married and for 1 to 2 years with regular sexual intercourse without using birth control. They have to be investigated thoroughly and assessed from A to Z, like Dr. Francisco has mentioned, to consider a clinical assessment, female assessment, and male assessment. If you are older than 35 years old, the evaluation recommended after 6 months. So see, the period of 1 to 2 years has reduced to 6 months because we are running short of time. If you are at age of 40 or more, so you have to speak to your doctor immediately after marriage to discuss the plan of conception. As per the graph here, showing you as the maternal age advancing, the quality of egg getting more less. Normal DNA, it will be less, and abnormal oocytes with aneuploidy will be more. According to this table, as per literature, at age of 30, the aneuploidy of oocytes accounts for 20%. At age of 35, it's raised a bit of 30%. At age of 40, double to 60%. After 40, 42, 85%, and more than 90% aneuploidy of oocytes at age of 45 and above. So it is a biological fact that a woman and a man age, their potential to have children decrease, although the exact time when this starts to happen can vary among individuals. We all know someone who had a healthy baby in their late 30s or early 40s, but of all people who try for a baby at a later age, many will not have the baby they hope to have. Across the population, women younger than 35 and men younger than 40 have a better chance of having a child than people who are older. This is true for natural pregnancies and for pregnancies conceived through assisted reproductive treatment like in vitro fertilization. So, what is the other way to preserve the fertility if in case of advanced maternal age? Currently, there is no medical technique that can guarantee fertility will be preserved. If you know that you want to have children later in life, one option may be in vitro fertilization, where the sperm is combined with a woman egg in a laboratory. If the sperm fertilizes the egg, then it will grow and embryo will be transferred. But is this the only solution, or is this the excellent solution? Some people think that the IVF is the answer for postponing their pregnancy to a later age, but actually it is not. IVF can help people with infertility to have family, but the technology cannot make up for natural decline in fertility that happens as a woman and men get older. Even though women today are healthier and taking better care of herself than before, improved health in later life doesn't offset the natural age-related decline in infertility. It is important to understand that fertility decline as a woman ages due to the normal age-related decrease in the number of eggs that remain in her ovaries. This decline may take place much sooner than most women expect. What is the other modality than IVF to preserve fertility in case the mother, the lady has a reason to delay her conception or her fertility? There is another modality called egg freezing, where the oocytes will have cryopreservation. Freezing of your eggs has become more popular in the recent years. In this procedure, several eggs are removed from the ovaries and the unfertilized eggs are then frozen for a later use in IVF. Who should think about egg freezing? Egg freezing, it is, as I mentioned, for those who is planning to delay childbearing, and it is recommended mainly for women having cancer treatment that will affect their future fertility. But this is not, there is no enough research to recommend the routine egg freezing for sole purpose of putting off childbearing. According to the publication from Fertility Sterility, they have investigated the reasons behind delaying the childbearing time, and they found that 88% of the ladies, they will have lack of partner because of lack of partner. And as you know that in our country, because of delayed in marriage, 24% professional reasons, 15% financial reasons, 15% also too large of a commitment. They are not happy to take the responsibility of the family, and others accounted for 8%. I put for you a few examples from the daily practice that I face with my subfertility couples, and this indicates lacking of age factor importance. The people still, they are not aware about the age importance for a lady. One of the scenario, one of the men, he told me that since my wife getting monthly menses, it means that she can be pregnant easily, even if she is 44 years old, because he was surprised. He brought his wife, she was 45 years old and not conceived for the last 5 years. She is para 6, and when I told him this is because of the age issue, he was unhappy, and he told me this sentence: since she is getting regular menses, that means she is fertile. Another scenario, she got married at age of 39 years old, but she seek medical advice at age of 43. So she was late by 4 years. She was waiting for natural conception. She is not aware that she is losing the time, the value years that she was having after marriage. The third scenario, she is second wife since 5 years. He is 65 years old man with 7 kids. She reported at age of 44 seeking for medical help. She is unaware that now it is too late to ask for subfertility treatment. Also, I found that some couples are not aware of IVF, or some of them, they know about IVF, but they're thinking it might be against the religion. So they need a lot of counseling to explain to them about the IVF, the meaning, the concept, the process, the issue of confidentiality, and so and so. Also, I found that unmarried ladies, for any reason they have, unaware about egg freezing modality. Even some of them are educated, and I got some of the ladies who are highly educated at age of 46. When they planned their marriage that time, they found that their hormones are very high and no time for subfertility treatment, and they were regretting that they don't know about this egg freezing and no awareness, and they didn't do this previously. So we should raise the awareness of the age with ladies from fertility view. And for a patient, don't defer childbearing. For professionals, don't defer fertility treatment, and don't defer IVF treatment for a woman over 38. Younger women have more and healthier eggs than older women, and younger men have more active and better quality sperm than older men. The second part on my presentation about the lifestyle and fertility, you know that our fertility can be affected by different issues in our life, can be affected by the radiation, pollution, chemicals, drugs, smoking, by stress that we are facing daily, obesity and eating disorder, by our sedentary life, and more and more things that can affect the fertility. As you see here, the health is affected by several factors on daily basis. My concern mainly in this webinar about the obesity and diet. We have obesity clinic in Royal Hospital. We have dietitian service in every health center and hospital in Oman, but unfortunately the percentage of obese ladies seeking infertility advice is still high. So we have to raise the question mark. Why? Women who have a body mass index of more than 29 should be informed that they are likely to take longer to conceive. Women who have body mass index, their BMI is more than 29 and not ovulating, should be informed that losing weight is likely to increase their chance of conception. Women should be informed in participating in a group program involving exercise and diet advice to reduce their weight. That will they will get more chance of pregnancy than only lose weight alone. Women who have also body on the other extreme, also the underweight, if the BMI is less than 19, with irregular menses or even some of them not menstruating should be advised that increasing body weight is likely to improve their chance of conception. In Oman, more than half of Omani population are now overweight or obese, with 30% of the population having BMI of more than 30, and this is really a scary number. These figures show a rise in the prevalence of obesity in Oman since the last survey in 2008, especially amongst women. This is the picture of the book that published and launched by Ministry of Health this year. And here, Dr. Ahmed Al-Saidi was launching the book, and he said the causes of obesity are complex, but one of the key drivers is in the way we eat and how much we move, which is changing dramatically. Impact of obesity and infertility is mentioned in literature several times since in the past and continuing on till now with all the evidence. If you will see this chart, there is a lot of literature published, each one discussing what type of impact of obesity on the infertility. 30% to 47% of overweight women have irregular menses. Obesity decreases the fecundity even if the lady is ovulating, but still it is not a must that the egg will be good for fertilization. Ovulation and pregnancy rates improve after weight loss. Obesity decreases the IVF pregnancy rate. Obesity increases requirement for gonadotropins. The risk for spontaneous even if those ladies got pregnant, the risk of spontaneous abortions increase in overweight, as well as the risk of preeclampsia and gestational diabetes increase. So the practical recommendation in obesity, the lady has to lose weight to improve her ovulation, to reduce the requirement of those fertility drugs, to reduce the risk of miscarriage and other complications. Also to have a good body image, look and feel better, and to help us in solving the dilemma of delaying treatment to allow loss of weight. We are losing a lot of patients coming for a treatment, but because of her BMI, we will advise her to go to dietitian, or even we will refer her to obesity clinic. She will disappear, and again she will come next year when her age is 1 year added more and still the same weight, if not more. So losing weight and concentrating more on how to reduce the body weight and obesity is very important. So what is the trend of modern lifestyle? To have, for the ladies, I mean, they will think about older, fatter, stressed, tobacco intoxicated, and infertile, but she is having a career and she can afford assisted reproduction. But we need to cut down in this trend of modern lifestyle. We have to boost our fertility by advising the lady for exercise, healthy food, distress, and a lot of other issues that it will help her to improve her weight and improve her diet. There is a lot of literatures in online. You will find that discussing about the exercise and ovulation, about the impact of lifestyle and diet and exercise on fertility, the effect of physical activity on reproductive health outcome in young women, and so many publications discussing the same topic. You need to boost your fertility with a healthy diet, and you have to take the advice from specialized people like dietitian, and improving the referral also to obesity clinic to Royal Hospital. In conclusion, apparently the lifestyle factor that has the most detrimental effect on fertility potential seems to be the social trend of having career before a family. We need to make people aware of the consequences. They could deal with both goals in a much more efficient way. We should be able to slow down this trend, then we could do better. And thank you. Shukran jazeelan.
Thank you very much, Dr. Muna. Thanks a lot for bringing up to light two very important issues in women seeking fertility. So thanks a lot for such a wonderful talk. I'm also very happy with the interaction that Dr. Francisco have established on the chat box. Some of the participants are posting questions and he have replied. So please continue to do that, and appreciate that the speakers also have a glance at the chat box every now and then. And thank you, Dr. Muna and Dr. Francisco, for being on time. That was great. now I would like to introduce I like actually the collaboration that happens in such activities that we are carrying. And everybody knows, I think, that fertility and laparoscopy or surgical intervention requires quite a bit of support from the industry. And we are very happy and we are thankful for the sponsorship of Sanofi for this webinar. And for our guest speaker, Dr. Saeed Al-Kindi, he is bringing the flavor and continuing on the tone that Dr. Muna have finished, which is the effect of obesity on the fertility. Also, Dr. Saeed, I'm sure he will touch on related subject related to related to weight. Dr. Saeed is a hematologist. Hematologist by training. He's a graduate of SQU and he completed his hematology residency training in OMSP in 2013. And he have done hemostasis and thrombosis fellowship in McMaster University, Canada. After the fellowship, he have established the thrombosis and hemostasis services at Khawla and Nahda hospitals, where we know that these hospitals are receiving the referrals from all over the country. He participated in lots of literature writing and establishing guidelines in the institutions that he have led care into. And he wrote clinical guidelines for women and thrombosis at Khawla Hospital and the national guidelines on coagulation testing. With no further ado, I welcome you, Dr. Saeed, very much for joining us tonight and for your talk on VTE prophylaxis during pregnancy and postpartum. Welcome, Dr. Saeed.
Thank you, Dr. Mariam. I would like to thank the organizers for inviting me to talk about this subject and Sanofi for sponsoring this subject. Well, without delay, I hope you are seeing my presentation now.
Yes, we are. We do see it, yes.
Yeah. So, thromboprophylaxis is a subject. It's a hot subject for pregnant women, of course. And
maybe you can share. You can put it on slideshow from down.
Is it now in slideshow?
Yes. Yes, it is. Thank you very much.
Thanks. So basically, my presentation is going to cover these areas. I'm going to go through the statistics illustrating the importance of VTE in pregnancy. And then I'm going to touch pregnancy VTE risk factors, specifically those which are very high risk, such as previous VTE and family history and thrombophilia. And I will touch on quickly on hematological risk factors. And then also I will go into obstetric clinical risk factors. And then I'll try to provide an algorithm to navigate the risk assessment. So which women should and which women should not receive prophylaxis, and a special highlight on methods. It would be lovely to see this list go bigger than this, but for the purpose of this presentation, this meeting is sponsored by Sanofi, who are the main provider of low molecular weight heparin in its form given to women either for prophylaxis or therapy. I'm going to start with a case. So usually the cases vary between one which is high risk or intermediate risk or low risk or only obstetric risk. And a case ordinarily would be like an age of, in the childbearing age with 12 weeks pregnant, who had no personal history of VTE, and she has a family history of VTE. And then the question is, what would we do, and how to determine whether we'll offer prophylaxis and for what duration, is it postpartum or antepartum, and how will we manage labor? If we look at the general population risk of VTE, we will find that it is 1 in 10,000 for the same segment of age of childbearing age. And if we look at the studies that looked at the VTE in pregnancy, we'll find that it ranges between 0.5 to 1.72 per 1,000 pregnancies, which if you take the average of would be 10 times the VTE in general population. Of course, the issue here is that they are still in absolute numbers low. Why would we make a big importance of it? And the reason is this is very preventable cause of mortality. If you look at the UK confidential inquiries since 1955 till today, we will find that the mortality of thrombosis in pregnancy has currently in the range of 0.8 deaths per 100,000 pregnancies. And that is a third leading cause of mortality in pregnancy, thanks to prophylaxis, because it used to be the major cause of mortality prior to that, like prior to 2011, 2010. Of course, the numbers are lower in some other countries, but the death that has come down illustrates the importance of this subject. If we look at well-conducted trials, instead of registries or case cohorts or or retrospective studies, we'll find that one of the important studies, TIPS study, done by Mark Roger in Ottawa. He has found that the risk of bleeding antepartum and postpartum differs for a woman who have thrombosis, and that usually, ordinarily, in the field of thrombosis, we accept the risk of bleeding if we give any form of prophylaxis, if the VTE risk is 3 times that risk of bleeding. So if you look at the antepartum, if you look at the confidence interval and you take the worst case scenario, which is the upper limit of the confidence interval, and you multiply it by 3, you will find that an acceptable risk to be taken so that you give the risk of bleeding of 2% all over is for antepartum has to reach 2%, 1.8 the minimum, and for postpartum 3%. Guidelines have varied. For obstetric guidelines, they used 1% as a threshold for prophylaxis, and thrombosis and hematology guidelines have been 3%. Now, one has to think about whether the side effects and inconvenience plus cost and medicalizing pregnancy, which was not necessarily needed, the prophylaxis, would be taken as altogether as drawbacks of offering prophylaxis to push away a VTE risk, and then you would offer prophylaxis. Of course, the postpartum period would have a higher risk of thrombosis, and also it is shorter duration, and you can still also use warfarin, which is less cumbersome than low molecular weight heparin injections. But this validation has not happened, and somebody has to validate this approach. So the first risk factor that we think about when we discuss thrombosis risk in women is prior VTE. And prior VTE, if you look at studies, depending on the quality of the study, between prospective and retrospective, you will find the risk is 2.4 to 6%. Now, if you dissect those into OCB pregnancy related versus no other risk factors causing it, so other risk factors such as surgeries and infections or unprovoked, you will find that the biggest player for predicting thrombosis in pregnancy is the fact that the prior VTE happened during hormonal stress. And the second player is if the VTE was unprovoked, i.e. came out of the blue. Any thrombosis that happened in the setting of infection or surgery or trauma would have a negligible prediction value for the occurrence of thrombosis in pregnancy. And then depending on the study, the numbers would vary, but if we look at TIP study again, which is well-conducted study, we'll find that provoked by hormones plays the biggest predictor for thrombosis in pregnancy, and then followed by unprovoked, i.e. came out of the blue. The provoked that are not related to hormones go as low as 1% only. With that in mind, if we look at the recommendation in guidelines, we'll find that the ACCB guideline, which is the thrombosis and hematology guideline, has agreed with the gynecology guidelines for the provision of prophylaxis postpartum entirely, and antepartum for those with hormonally stressed thrombosis or unprovoked or multiple prior VTE. It did not agree with the prior VTE that was not caused by hormones. And there is also a small caveat that the ARCO Green Top guideline needed to see that it was prophylaxis, that it was caused by major surgery. That was not caused by major surgery. And then after that, after 2005, another guideline came to use, which is the American Society of Hematology guideline in by the end of 2018. And this guideline is actually was written by the same group of the ACCB group, the hematologist and thrombosis expert, mainly from North America, but from other experts from Europe as well. And what the guideline shows that it examined all the studies, and it found that there is an incremental benefit of antepartum prophylaxis of reducing the risk from 4.2 to less than 1% for women with prior VTE. And for postpartum, the benefit is even higher, with 6.5 going to 1.8. This benefit is only seen in the only surgical setting of high-risk orthopedic procedures. So now we move to thrombophilia, and then we examine whether thrombophilia should be a predictor of the thrombosis in pregnancy or not. For thrombophilia, you would see that factor V Leiden homozygosity plays the biggest predictor, and then followed by prothrombin gene mutation, and then others such as antiphospholipid antibodies. Now, if you multiply these odd ratios by that number of 1.2 per thousand, you will find that the occurrence happens at these rates. And again, it's higher, of course, to factor V Leiden homozygosity, but not heterozygosity. And the numbers are dramatically different. And the same also for prothrombin gene mutation. So taking prothrombin gene mutation alone in heterozygote state should not be a practice that takes the risk of prophylactic bleeding. Now, if you add to that family history, you will find that all of them are bumped up. And that also explains where the guidelines will go sideways and would not agree, because the thrombosis experts saw that the importance of these thrombophilias was mainly driven by the fact that family history were positive. So if we look at the guidelines, when there is no family history, we find that the ACCB did not agree to offer prophylaxis, and only during antepartum period, but only postpartum where the risk is higher. When family history was present, ACCB joined ARCOG and ACOG and gave a recommendation for antepartum. And so an important tool here is to obtain the family history of VTE. The newer version of the ACCB, which is the ASH guideline, have dissected these beautifully, and these slides are available in their website that you could print and keep them in the clinic. When a low risk of thrombophilia is present and family history is positive, for low risk, it does not give the threshold to offer prophylaxis, both antepartum and postpartum, for heterozygote factor V Leiden prothrombin gene mutation. For protein S, if a family history is positive, it would give only postpartum. For antithrombin, if a family is positive, it will give both antepartum and postpartum. And the reason here is that antithrombin deficiency only comes in heterozygote state because homozygous state is incompatible with life. So it is a higher risk than protein S and C deficiency, but still not as high as these ones, which are homozygous prothrombin gene mutation, homozygous factor V Leiden, and combined, or what we called compound heterozygotes of thrombophilia, this and protein S or factor V Leiden and prothrombin gene mutation. Now, you will notice here is that in homozygous factor V Leiden, regardless of family history, the recommendation is to give prophylaxis throughout. And the same for compound thrombophilia. For homozygous prothrombin gene mutation, the studies were not weighed enough to give formal recommendation, but the group favored antepartum as well as postpartum. Moving from thrombophilia to antiphospholipid syndrome, which is a unique group of thrombophilic state. It is acquired, and mostly you should refer to hematologists interested in the field. But in general, if the lady had antiphospholipid antibody syndrome and has a history of prior VTE, definitely you would give 6 weeks postpartum. You would discuss antepartum. If it was provoked by hormones, you would give. If not provoked by hormones, you would look at antibody profile and systemic autoimmune disease, and then factor into it maternal preferences. The same happens for women who does not have prior. You would not rush away and give prophylaxis. You will discuss, you look at profile, look at other clinical risk factors, i.e. ARCOG guideline. A special emphasis and a quick one on other thrombophilic states such as myeloproliferative neoplasm. You can always refer these to hematologists, but in general, they need aspirin throughout pregnancy. These women, they may have hemorrhagic event in the past or thrombotic event. If they had one of these, then they are at risk of thrombosis. So hemorrhagic event in essential thrombocythemia and polycythemia rubra vera is a risk factor for thrombosis during pregnancy and elsewhere. And so if the thrombotic event was, if there was a vascular event, then you would offer 6-week post-delivery prophylaxis. And if there was thrombosis that caused the vascular event, then you would actually increase the dose to from week 16 to BID prophylactic dose. Now we're done with these thrombophilic states. Now we discuss the obstetric risk factors. And these risk factors, please just remember few information. The first thing is that if you notice, all of those recommendations we discussed prior to this slide were all in C's and B's. So there is no great data and information behind them. And the same applies for these risk models. The most popular one of them is the ARCOG Green Top Guideline published in 2015. And it goes on and on looking at these risk factors such as obesity, parity, smoking, varicose vein in that woman, and then other obstetric risk factors such as preeclampsia, multiparity, and a special emphasis on some conditions such as emergency cesarean section and ovarian hyperstimulation syndrome. And the guidelines specifically highlight that it has to be severe type and only until resolution. Now, if you find that all of the above mentioned case conditions such as unprovoked or provoked by hormones or family history plus thrombophilia was negative, you will go to obstetric risk models. And the obstetric risk models, they will take into consideration multiple factors. They will score them. If they are 4 or more, they will go from first trimester. If they are 3, they will go from 28 weeks, and 2, they will consider for 10 days postpartum. Now, one thing to remember is that these models used a threshold of 1%. And so you should bear that in mind when you are applying them. So in summary, my mental algorithm of going and offering women prophylaxis the right way is to look at if the woman had unprovoked or hormonally provoked, and then straight away give prophylaxis throughout antepartum and postpartum. If there is special hematological population, then I examine it event-wise and antibodies-wise and lab-wise, and probably you would feel more comfortable to consult a hematologist on those. And then look at thrombophilia, and if it is high risk, prothrombin gene mutation, homozygosity, compound thrombophilias, and prothrombin gene mutation, homozygosity, and then you give prophylaxis throughout, just like this. If they are low risk, protein S, protein C, or heterozygotes of the other 2, which I mentioned before, then check family history, and also antithrombin. Check family history. If it is positive, use ASH tables and give prophylaxis, whether it is postpartum or antepartum or both. If you find that you are in a situation where you ended up with only postpartum, go back to ARCOG and score more. That woman could have other risk factors. And if ARCOG qualifies her for antepartum, add it to the regimen. If the patient had provoked VTE, then score ARCOG. VTE, which was provoked by in a surgical setting, is not a risk factor for pregnancy VTE. It should not be taken alone, and it should be taken into consideration with other risk factors. And again, if all of these are negative, then you move to obstetric risk factors only, and then you score ARCOG. So a practical advice about this is that to print the ASH slide sets, there are actually only 2 pages for thrombophilia, and clearly, easily you can navigate the patient where she sits. And if it is negative, you should first do unprovoked and hormonally provoked, and then family history and thrombophilia from slide sets of the ASH. And then you've done with these, then you move to ARCOG and score her. I used to advocate for Saskia middle door chart, but now with ASH slide sets available and easily navigated, then this should not be a practice. Now I'm going to quickly go into methods. And for methods, the first thing is we need to remember that low molecular weight heparin that should be used during pregnancy is in its pre-filled syringes form to prevent infantile apnea syndrome that is available on other formulations of low molecular weight heparin because the preservative causes infantile apnea syndrome. So only pre-filled syringes and only fixed doses. There is a good meta-analysis done by Greer in Blood in 2005 for many studies about the risk of bleeding during prophylaxis in pregnancy, and it goes up to 2% altogether of bleeding. There is a small percentage of 1.8% of allergic skin reactions. Otherwise, platelets do not go down. The risk of hit is very low. With low molecular weight heparin, you should not worry about it, and you should not monitor platelet when the patient is on low molecular weight heparin. And osteoporotic fracture is very low as well. So for these matters, you should not worry when you are using low molecular weight heparin. An important subject is what to do near delivery. And the recommendation of the newest guideline have gone with the recommendation from anesthesia guidelines where 12 hours interval is needed for the use of epidural and spinal anesthesia. Now, there are many studies that have shown that if you schedule a delivery for these women, you do not actually reduce bleeding, but only increase that small risk that you wanted to avoid for that using that prophylaxis of VTE events. So the general recommendation now, when you are using a prophylactic dose, low molecular weight heparin, do not schedule delivery, do not interrupt anything unless that woman is very eminent about that 12-hour and that spinal anesthesia. If she is okay with either form of anesthesia, or you as a practicing OB-gynecologist is very keen about that anesthesia and you want to keep those 12 hours window, then you can schedule. There is a reason for this, is that because most women, when they start delivery, by the time they arrive at the hospital and they are near to delivery, they would have taken most of those 12 hours. So for labor, do not schedule delivery, but educate the woman not to take any low molecular weight heparin once labor pain starts. Regional technique can be used, and that's 12 hours in keeping with anesthesia guidelines. And low molecular weight heparin should not be given for 4 hours after use of spinal anesthesia or after the epidural catheter has been removed. And the catheter should not be removed within 12 hours of the most recent injection. For women who are planned for elective cesarean section, she can receive the prophylactic dose the day before and omit the dose of the morning she is doing the surgery. So we go back to this case. She's a 36 years old. She's 12 weeks pregnant. She has no personal history of VTE, and she has a family history of VTE, and further inquiries found that she has a protein S deficiency. So per that ASH slide set, easily I could navigate. She's only for postpartum. And then because she has had family history plus protein S deficiency, she goes for postpartum. If she did not have family history, I would not give in her. And then so it's only postpartum. So what to do about antepartum? Well, next, you score ARCO. She could have other risk factors. If she scores enough, she goes for antepartum. And so this is the way to navigate this. Now, the issue is if a woman comes with family history only, but thrombophilia could not be obtained, she wasn't tested before, then what to do? Well, you can give her the benefit of the doubt and give her postpartum prophylaxis for sure, and then score her ARCO as well. As I said, having that protein S deficiency is not necessary a piece of information to plan the prophylaxis practice, and should not be done because many reasons, but should not be done at the first antenatal clinic. And one of them is protein S is lower anyway during pregnancy. But then again, it is not a practice to do a very expensive test to plan prophylaxis. And then the rest of the case where which agent to use is clear from presentation and how to manage labor. So in conclusion, the data behind prophylactic practices are not the best used in clinical evidence, and the mortality and morbidity of women at childbearing age caused by VTE is a significant clinical burden that needs strategies to have a clear understanding of the variable risk factors and benefits of prophylaxis, and not to treat all of them as similar beasts. A meticulous use of clinical information is important, and a risk assessment for consideration of prophylaxis and a proper antepartum management. No role of thrombophilia testing in deciding prophylaxis, and the agent of choice is low molecular weight heparin in PFS form. Thank you very much for allowing me to conduct this presentation.
Thank you very much, Dr. Saeed. Actually, a very interesting way of simplifying the decision-making process. And I think I'm actually sure that many of our participants have taken a snapshot of the algorithms for simplifying the decision making. So thank you very much. It was a very interesting talk. And maybe some of our participants can share their questions in the chat box. And meanwhile, you can, if you have some time to actually also in between have a look at the chat box and maybe answer some of their questions if they post any. And thank you very much for your interesting talk, Dr. Saeed. Now, actually, I would like to introduce our next speaker. Our next speaker is Dr. Mazen Al-Khabouri, who is the Director General for Private Health Establishments at the Ministry of Health. MashaAllah, Dr. Mazen has a very rich career in ENT. As of training, as a specialty of his training, as he graduated from the University of Ain Shams in Egypt, then followed by being a fellow for the Royal College of Surgeons and Physicians of Glasgow. And after that, he had a PhD in the University of London, researching genetics and clinical deafness in Oman. He have been a senior consultant at the ENT department at the Nahda Hospital, and he have been developing and taking care of the ENT services in Oman since 1996, mashallah. He actually headed the department of ENT at the Nahda Hospital, and he worked closely with lots of international organizations, including WHO, for programs responsible for teaching and of ENT and hearing loss. Then he went into higher administrative posts in the ministry, where he was an advisor for the clinical services about the clinical services for the Minister of Health, and then the Director General of a private health establishment in the Ministry of Health since 2014. And because of the advanced fertility management happens mainly in the private health institutions in Oman, and Dr. Mazen is the Director General for the private health establishment, he was kind enough to agree and join us and join the group, trying to put some lights on some of the hot subjects and answering some of our questions. Dr. Mazen is, you are most welcome to talk to us and give us some answers to the question where centers managing infertility in Oman, where are we? And of course, you are the authority to answer. So most welcome, Dr. Mazen.
Thank you, Doctora. I'm just trying to I tried it before, I remember, and I'll try again to share screen. Here we go. Yeah. First of all, I would like to thank you for asking me. Rahma asked me a time ago, and I've been working with all of you for a long time, as I will show you in my slide. Actually, I would like to thank Dr. Mahal Khadouri. When I was advisor to the minister, 2010, she opened, I know all of you. I knew her, and she just opened the door and came into my office. She said, I want to talk to you. And I said, okay, what do you want to talk to me about? She said, everybody is writing one second, how do I go to the next slide?
Enter or an arrow down.
Okay. So she said, everybody is writing these fertility drugs, and I want to do something about it. I have no idea what are the drugs, etc. And this is how the dialogue started. And actually, then I did some research, and I found that the fertility mostly was, especially IVF, is exclusively done in the private sector. The first one started in November 2001. There were 8 centers. Recently, a center was closed. And at the moment, 7 centers are active. So what is an infertility treatment in Oman? As I said, there was a lot of infertility treatment. 2010 is when I was asked by the minister to become his advisor. There was management of infertility without much supervision, and the drugs could be given by anybody, actually, even a pediatrician, but I don't think they were giving this. By GPs, any specialist in obs and gynae in private, and there were some of them were very famous. For anybody who wanted to go become pregnant, you know the person I'm talking about, they would go to her and she would then give them these drugs. And there would be some sort of casualties in the hospitals with overstimulation, etc. I had no idea about it. So, and also at that time, Dr. Rahma, I think she was still doing her fellowship or just come back and raised concern about these things. And I had a discussion with the minister and he said, go ahead, do something about it. And the first thing I sat down was write to the private health establishment, at that time, Dr. Saif Nabhani, to stop people giving these fertility drugs, except those who were qualified and had some knowledge of giving them. Then I formed a group with Dr. Amaha and others to discuss how we can improve the situation, because a lot of you people were coming back from abroad, and this was an ad hoc group. It wasn't official group. We just started discussion, and at one time even the religious people were involved, and slowly we could think of something. Actually, this was much before 2013. We made a draft copy, fertility centers, and we thought, let's make the standards for the whole country, private and public. And then 2016, when I became the Director General, we formed it. I had actually didn't want to be part of it. I asked somebody else to be part of it, but the Undersecretary made me the chair, and these were the members. And there were other people I would like to mention. One of them was a lady, maybe you don't know her, or you don't know her. She was an embryologist, young embryologist. Sohal Malki. So we started working on the regulations officially in 2016. 2017, this copy, and from 2000 to 2017, discussions were going on. Dr. Rahma Al-Ghab, she was very active, and she would give us a lot of advice. I would also talk to Dr. Majda, who was in Muscat Private Health, and before that she was in the Royal Hospital, and many others would come and go and to formulate. But then I did not know that you have to have a qarar. But at the moment, we are following these guidelines. Anybody who opens, they have to go through these guidelines for centers. So how did it become more famous? Because at one time, the Ministry of Health added IVF in the treatment of abroad ailments, and they, instead of sending them abroad, they would, from 2012, they would pay for the treatment outside and then inside the country, and it's still going on. So 2000 till 2015, they would send patients abroad, and then it stopped in 2016 because, I don't know, the number of pregnancies were not good. And from 2016, they would take people inside Oman to get the treatment. So Dr. Rahma asked me, how do you open a center here? I said, you go to anybody who wanted to open an IVF center in Oman, they would have to follow these draft rules and regulations. And by the way, my main aim was not to do the private thing. Before I became the DG of Private Health Affairs, As an advisor, we started plans to open an IVF center in the Ministry of Health in the Wutaya Gynae Center, where, after we had Shifa, we had space, so there was no need for medical record files, so that area was dedicated. And we had lots of meetings, drawings were done, we had approval from the finance, and but it disappeared. So one day we will achieve that to have an IVF center in the government. So how do we monitor them? We do regular audit visits to these centers, and sometimes, which is at least once a year, and then we correspond with them, asking about their problems, or if we have any concerns or complaints from anybody individual or from the government office, that we go and visit and talk to them and do an audit regularly. And if you want a clinical audit, we ask one of you people, one of the groups which I mentioned before, to create a small Quran, Amar Taklif, or I don't know what you call Amar Taklif in English, to go and visit the center and see what's the problem. So I'll give you some figures. Sorry, it's in Arabic. This is an advanced IVF center. They are one of the oldest ones, and they have and the success rate is between 36 and 47% of all ages. The highest age group is from 25 to 35 naturally. This is an art which Dr. Ruiz had just given us a talk about. This is their figures that it's from 2017, they had 66%, and then it varies within the range, and they have done this number of IVF cycles.
Dr. Mazen, sorry to interrupt, but the voice is very faint.
My voice?
Yes. It dies in between. It goes as if it is far. I don't know if your mic getting covered by something.
No, it's I will put my earplugs. Just 2 seconds. Wait for me. Okay. Can you hear me?
Yes, we can. Yes. Yes.
Okay. So this is figures from New Hope numbers, and this one, some of them have given us fresh and frozen figures as well, which might be interesting to you. The next one is Al-Azhar Hospital, embryo transfer, the number of group.
Dr. Mazen, we lost the voice again. I'm sorry about that. We lost the voice.
Hello?
Yes, we can hear you now. Yes.
Okay. So that was Azhar, pregnancy rate for all cases. And then, as I was saying, if any of you, the group, are interested for research or, for their interest, you're most welcome to get these results from us. These are official results sent to us by them. This is Al-Faqih. Their range of success is between 55%, and up to 2020, it's again similar results. Again, similar results. And this is our final copy is 2021, which is now gone to the ministry for final, now we have the Center for Taman al-Jawda for quality assurance. They have to approve all guidelines and circulars. So we had to change our guidelines and circulars according to their template. So this is all. I think I've answered. I hope Dr. Rahma's all questions she has sent me. If there's anything else I can help you with, let me know.
Great. Thank you very much for sharing such information. We appreciate, Dr. Mazen, if you stay with us till the end of the webinar. After Dr. Rahma's talk, I'm sure the participant will have some questions for you, and even lots of our colleagues from the fertility side, if they have any questions for you, that would be fantastic. Thank you very much for being with us. No problem. Thank you. Thank you very much. Now I would like to introduce the name that you guys have heard from the beginning of the webinar, I think, Dr. Rahma Al-Ghabshi. طبعا Dr. Rahma does not need any introduction when it comes to the activity of both the Oman Society of Obstetric and Gynecology and the Oman Fertility and Gynae Endoscopy Group. MashaAllah, she has been active at all levels. She leads lots of fertility effort and liaise with the Ministry of Health, of course, with all the names that Dr. Mazen also have mentioned, like Dr. Maha Al-Khadouri and many of our colleagues. We appreciate all their effort and their trial and interest into trying to improve the care for the fertility aspect. Dr. Rahma Al-Ghabshi is a senior consultant at the Royal Hospital. And as you have heard, she has been very active in the guidelines related to fertility management in Oman. Dr. Rahma will be talking to us about her thoughts in organizing the fertility care in Oman, and she has been carrying this burden and this advocacy for patients' care. Her talk is titled, "Is there is a better way to organize fertility treatment in Oman? Possible guidelines." Dr. Rahma, you are most welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you can all see my screen. Is it okay, Mariam?
Yes, yes, it is.
Thank you very much for your introduction, and good evening for everybody, the Friday night. And I hope I will get your attention for my presentation after a long talk this evening. I will start with the outline of my presentation. I will talk about the infertility as a global public health issue, the prevalence of infertility worldwide and in Oman, the gap in fertility treatment in Oman, the need for the private institute fertility service, the suggested levels of fertility levels in Sultanate of Oman, that is the suggested levels which we submitted to the Ministry of Health and hope we will get the approval for it soon. The possible codes and regulations, which we also hoping to be, and I think it's already there, and we hope that it will continue in the new draft in 2021. Checklist for the IVF centers in Oman, which we usually do it when we go and visit these centers, and challenges and useful regulations and how to pick up a fertility clinic. To start with, I want to show you this map. This map shows the fertility rates in since 1970 and in compared to 2014. As you can see that here, that we were in Oman and most of the Gulf countries and North Africa, we were getting 7 to 8 children per woman in 1970. I want just to show you how much the fertility rate drops in the last 40 to 50 years. So in 1970, when we were like in Oman, 7 to 8 children per woman. If you can see the below, the same area dropped to 2 to 3 children, 2 to 3 children per woman in just 40 years. Not only that, that dramatic change in the number of children per woman, not only in the Gulf or North Africa, but most of the world, some of the areas are stable and some having a very dramatic decrease in the number of children. I know most of you will say that in the last 40 years, the women are not same. They are more out, they are educated more, they are looking after their careers, their educations, they are working. So that's why they choose to be to have less number of children to look after, because they cannot cope with the demand of both looking after the family and looking after their job also. Well, maybe that is not true for some areas. Maybe for some areas it is yes, but for others it is not. According to WHO, we have a fertility issue worldwide. 1 in every 4 couples in developing countries are facing an infertility. So it is not a choose by the couples to have a decreased number of children or not to have children at all. It is an infertility issue. It is a problem that which face around 48.5 million couples. And it is a neglected issue at the same time, not only in the developing countries, even in developed countries in some areas. Reproductive problems in both men and women are rising at an alarming stage. And that is only published recently in March 2021. So, and by many systemic reviews says that we do have a problem of infertility in the Middle East, Sub-Saharan Africa, North and Eastern, Central and Eastern Europe, and Central Asia. So the problem of infertility, in fact, the prevalence, it goes from 5.4 couple facing fertility issue in 1984 to 8.5% of the world population to 15.7% in 2019. If we come to the individual male and female, 1 in 25 male are facing infertility issue, and some around 50% of the infertile couple having a male component issue, while 1 in 8 women will face a fertility issue. In some countries, like in USA, 1 in 8 couples are facing an issue in fertility, 1 in 6 couples in Canada, and similar numbers in UK. Some of the jobs are having more infertility issue than others, like here in this Medscape publication in 2008, that the military women, and I believe not only women, also men are facing more fertility issue rather than civilians. And the male infertility are becoming worse by years, and we are facing more and more infertility in males more than before. And that is in very alarming status, which make even the WHO changing their criteria of references to the male semen parameters from years. Like if you can see here in 1980, 87, and now 2010, and just recently, as Dr. Francisco mentioned, we have the 2021, where the references are becoming lower and lower, where that is fine as a state that these men can still, although they have low number of sperms or motility, still they can produce children or parent a pregnancy, but at the same time, we do have these decreases by numbers, in years. Why? What about Oman? We are no different than the rest of the world. As I mentioned earlier, the fertility issue in Oman is decreasing, it's increasing, and it's an alarming status. And as I said before, yes, in the last 40 years, we have more and more women are coming out from homes. They are looking for job, they are education, they are traveling abroad, and they have not much children. They are delaying their conception. and going to their 30s instead of 20s. Well, what we are seeing here, it is not because of that only, as I said earlier, we have a fertility issue in Oman. How is that happen? If you can see this graph, which I just could take it soon, I mean, late, in just a few days back, that in 2018, we have 2.89 child per woman in Oman. And that is going by negative year on year. In 2019, decreased to 2.84, and now in 2020, it's 2.78. Unfortunately, I don't have a proper figure from Ministry of Health says how much infertility incidence in Omani populations. But according to the statistics in 2013, female infertility cases reported by Ministry of Health to be 81 per 10,000 female population compared to 11 per 10,000 male population for male infertility. Based on the international estimation and on the previous figures I show you, that is highly underestimated. The estimated for the Omani population that they have 2.2% for the primary infertility and 2.4% for the secondary infertility, and the number of infertility cases are increasing in Oman. And unfortunately, some of these cases required IVF intervention and an ART in general, which is not available at present in Oman. We have a period of time from 2014 till end of 2015, beginning of 2016, before the economic crisis, that there was sent by Ministry of Health for fertility for the IVF, but unfortunately that stopped now. That is not only showed by the, Minister of Health, but also our colleague, like this statistic, this study was done by our colleagues in ART, showed that the Omani population have really an issue with infertility, like what Dr. Francisco mentioned before, and we have an issue with infertility due to different factors like lifestyle, eating habits, parental consanguinity, vitamin D deficiency, and infertility. In men specifically, it's related to their obesity, excessive smoking, steroid consumption, and largely consanguinity, as it's mentioned in the study. I think Dr. Muna already took you through this number of studies, which shows that we have an issue with tobacco smoking, semen quality and infertility in Oman. Specifically, 60% of adults in Oman, they are overweight or obese, and the female obesity is going up to 40%, and I think we have issue with lifestyle. In 2000, the data showed that about 5,000 cases were treated compared to 20,000 who required fertility treatment. That gives us a gap of about 15,000 cases who are not treated. This is really need a national program how to help these couples. The Ministry of Health having some fertility clinics all over the Oman, who is run by the general gynecologist. Some of these clinics, unfortunately, they don't have simple medications or intrauterine insemination. Male infertility, again, that part is really ignored or is not highlighted. And we need to look into it because there are unfortunately not much male fertility clinic are open under the Ministry of Health, and they are usually looked after by the urologist or dermatologist. And the complicated cases who require IVF, they don't know where to go, which is around 3% to 4% of all infertility couples. And this service, as I said, is not available in the Ministry of Health. And that's why we need the private sectors and we need the private service. Well, in the private, we do have an issue also, because the type of clinics usually run by the general OB-GYN and not a specialist fertility specialist. And we do have, like what happened in the Ministry of Health, we have an issue with the qualification of the treating doctor, not in the Ministry of Health or in both Ministry of Health and in the private. Availability of fertility specialists is not always there. And of course, as Dr. Mazen says, that we need guidelines and specification, and hopefully that we should be restricted, and we should have a better specifications and level of this clinic, which I'm going to mention it, and who should do the monitoring and how frequent. And of course, we need to look after the male infertility specialists. The market of the fertility and IVF specific is increasing worldwide. As you can see in this, how much fertility and IVF clinic is there in our region. It's very important then. With these numbers of more clinics and clinics open, they need to be monitored. So we do have, I wish that we have this sort of levels or guidance who can help the population, the fertility population in Oman, how to choose the clinics in order to go and have a proper treatment. And when I hope that this will be taken by the Ministry of Health. These, we divide them into 4 levels. These centers have to be given a certification, shows the type of the service, which I'm going to mention now. And these centers, when they move from one level to the other, they have to have a recertification from the Ministry of Health. So let us now move to the levels of these clinics, suggested levels. Level 1, it's the treatment with fertility medication. So this is the levels, suggested levels for any fertility treatment in Oman, and I hope this will be taken for all the fertility clinics, both in private and in the Ministry of Health. So for fertility, for level 1, the treatment with fertility medication, including oral and gonadotropins only. And this should be done only by board certified in obstetric and gynecology from a well-recognized institute with an experience in fertility treatment of less than 2 years. Of course, that doctor has to have some sort of experience in using ultrasound, vaginal and abdominal, and they have some helping doctor. Of course, nobody can work alone, and that can have a diploma in obstetric and gynae. Level 2, when you add to the level 1, the intrauterine insemination. So for that, you need a technician who is having a baccalaureate degree or equivalent, or a lab who can work in preparation, a proper preparation for the intrauterine insemination. So this is level 2. Level 3, when we come to the assisted reproductive technology, in vitro fertilization and ICSI. This, as Dr. Mazen mentioned, we have a specific codes and regulations, but what I want to here to emphasize on that it has to be run only by an REI specialist who is board certified from a well-recognized institute and a certified laboratory. So it cannot be run only by a fertility specialist who has only having a general OB-GYN and or some sort of experience in REI. They have to have an REI specialist. Level 4, when they are doing an IVF and with that BGTA, including BGD and BGS, it has to be also a certified REI specialist from a recognized institute and certified lab. And I believe most of our, if not all, of our IVF centers, they send it to a specific lab who are certified and already seen before by the Ministry of Health, and either in Oman or outside Oman. So the directorate of a private sector, that's what we are hoping to formulate a committee who is responsible to give this certification according to the level, and this certification has given to these clinics in order, and it should be there present in their reception. So when anybody comes to the clinic, they know what sort of service this clinic, this fertility clinic, are expected to give. And that certification has to be, going to the Ministry of Health, have to renew them every 12 to 18 months, and they have to be practiced according to the regulation or rules. Of course, For the ART, they have a specific regulations. The license holder have to be academic qualification, and the REI specialist should be run only by REI specialists, as I mentioned before. The online training of diploma of fertility for a few weeks in the field of reproductive medicine will not be accepted anymore to be recognized an IVF specialist. The staff of the IVF, the other staff, like in the embryologists, laboratory technicians, and others have to also be certified. The license have to provide, like what Dr. Mazen now he gave us. They give us, thankfully, every year regarding detailed yearly report about the number of patients they are seeing, how many cancellation rate, pregnancy rate, biochemical and clinical, and the complication rate. And of course, they have to give us also some sort of what is their backup in case of the absence of staff, resignation, to inform the authority and what they are supposed to do and who is going to help them in case of any emergency, and what is their strategy to minimize a multiple birth, which is a very known complication of IVF. And we are hoping that we are in any center, when they give us the number of multiple pregnancy, they're decreasing by years from 24%, which is, this is a figures worldwide recognized. 24% in first year of the multiple birth, then 20% in the second year, and after that it should be going 10 to 15%. If that center continue to have a high number of multiple pregnancy, they have an excellent lab, fine, good. They have a good number of patients, young patients who are highly fertile, that is very good. But also they have to put other strategies like what they are supposed to do to decrease the number of multiple, like single embryo transfer and others. So the codes of regulations also, we continue with that. There have to be documentation of the marital status of the couples. Third party, like donor sperms, eggs, and embryos, is prohibited in Oman. The center has to have regulations or what they are doing regarding the cryopreservation of the gametes and embryos in the secured and well-controlled access areas. Location of the gametes in the storage. Sex selection is prohibited in Oman, is not allowed for a social reason. Fetal embryo reduction is also prohibited in Oman. In the private sectors, I mean, that it's prohibited and it's not allowed, and it has to be done only in the Ministry of Health institutes. So usually when myself and my colleagues going to audit these centers, usually we do that almost every 12 to 18 months, and last time we did it in the 2019, late 2019, early 2020, before the pandemic, and we went to all the IVF centers in Oman, and we look into their how it works, since when, the certification of their license holder, and the doctors, the staff, especially the IVF consultant, the specialist with their qualification, their license, the numbers of patients, and usually, as I mentioned before, they give us their pregnancy rate of complications, especially the ovarian hyperstimulation syndrome, what is their annual birth rate, and we usually also pick up something like 2 to 3 to 4 files randomly from their patients, and we go through them in order to find out what is regarding their consent, and we ask them about their backup and all these things. And after that, we submit this report to the Ministry of Health, to the private sectors and Dr. Mazen's office for any recommendation, any comments, and when to do the audit again. And hopefully we are going to have that soon. So we all know that we are facing challenges in Oman. Qualification, doctor and staff in general, that is in government and in private. We need a qualified doctors treating infertility. We don't need a generalist. Male infertility also need their qualified doctors to be treated. Standardized semen analysis. Up to date, we don't, some of the centers, some of the labs still giving us 19s semen analysis parameters. Who should be doing the audit of the IVF centers? Shall we ourselves do the audit? We are the only Minister of Health staff? Shall we get somebody from outside auditors? Because we do face sometimes that ourselves working in private and at the same time we are going and audit ourselves. That is sometimes is not accepted for the others, which is, I think it is understandable. And so we need sort of talking about this issue, education of the community regarding their rights, and maybe the levels, getting these levels of centers will be very good things to be done. And we have to, as Dr. Muna mentioned before, health education is very important regarding the effect of age, ovarian reserve, obesity, and male factors. The useful regulations are very important to be adherent to. And any fertility clinic and IVF has to meet the certain basic standards. Regulations, both not only in private, also in government, has to be standardized, and guidelines have to be for everybody. For general OB-GYN, if they are treated by general OB-GYN, they need to know also, maybe we need sort of education for this, and when to stop treating in their institute and refer it to a fertility or IVF specialist. And again, male infertility, who should treat them? And very much we need IVF center in Oman, and hopefully we are inshallah going to have that soon. I hope inshallah. Need to protect infertile couples because they are already emotionally disturbed. Sometimes they feel that they are cheated. So all the IVF centers need to be transparent. They have to have a consent. They have to have their own papers, how to guide these couples regarding how to when they are treated in their institute. Just I put this, how to become a fertility clinic. This is also good in any fertile couple, infertility couple who are looking for fertility treatment. Maybe they should know before they go to any fertility clinic, are the fertility doctors board certified, reproductive endocrinologist, not only a fertility specialist, as I mentioned before. How many physicians are part of the practice? Unfortunately, some of the centers having only a single hand fertility specialist. So if that for any emergency issue, that doctor go away for any reason, for a sick leave, for a leave for any whatever reason, they are not around. Who is looking after those patients? What is their backup? As I mentioned before, that fertility center authority knows about it, that they submit their reports. What is their service they are providing, like an IUI, BGD? Does the fertility clinic have their own embryologist and andrology lab, or they are getting help from somebody else? What are their insurance? Are their insurance accepted? What they are supposed to do? Does the infertility clinic having other services like social workers, nurse guide 24/7? All these things, any couple who are looking for fertility treatment should know about these when they go and look for a fertility clinic. That is my talk. Thank you very much.
Thank you very much, Dr. Rahma. I think you brought up some of the burning issues that I think many of the participants might wonder and have questions about. They can post their questions in the chat box. I also can see that as previously we mentioned, Dr. Francisco and Dr. Saeed have been interacting with the participants and answering the questions kindly, and thank you very much for doing so. So far, I don't see new questions, but meanwhile, till the participants thinks about typing their questions, and maybe I can ask you and Dr. Mazen. Dr. Mazen, do you feel that based on what Dr. Rahma have mentioned and described, does the Ministry of Health, represented by the Directorate General of the Private Health Establishments, does it have the infrastructure to look after the establishment's guidelines, the licensing, the auditing, and the process that comes with the trying to regulate and elaborate on the governance of the infertility centers?
As Rahma has already mentioned previously, the guidelines were developed by you. I'm an ENT surgeon. So I was just organizing your people to develop the guidelines with all people involved. And together we developed the guidelines. And if somebody is going to audit, we only audit basic things which are to do with patient safety and infection control. The clinical audit has to be done by an expert, which is this group, doctor. But I always am ready to formulate a team to go and audit the group. And recently, I have asked the minister to form a committee, which will be a clinical audit and privileges committee. Once this committee is formed, we will have a central committee which will be represented by the private, Dr. Jamia from the Quality Assurance Center, and will have consultants with their teams from each specialty. And you will be given the task of officially to monitor within your specialty how it is worked in the private. Now, as Rahma had mentioned, they used to go regularly to do the audit. We have a baseline. We have the numbers and what they have, and it is available anytime in the private health sector. Who is working in each infertility lab or infertility clinic? What are the qualifications? And if you, as a group, feel that we have to become tighter, I have no problem, because it is you who are dealing with the complications, not me. You understand? And you are dealing with all the problems. So I prefer that it has to be self-regulatory. You form a group, public-private group, to look at your own interests, because a good clinic in the private will have more clients, and everybody wants to. The old days of doing things without telling us are gone. You can easily find out fi Balaghat, 24 hours hotline. Anybody can phone us and tell us there's something wrong going on. And we have closed clinics. I will not mention names of the person who used to give only clomiphene and do IUI. And as Rahma mentioned, was a specialist obs-and-gynae lady sitting in a small clinic with very horrible setup. And we closed that clinic for 6 months. And then we restricted that lady's privileges drastically. And she is now towing the line. I don't want to punish people unless I tell them the rules and regulations first. Let them know that what is ish alayhum, how should they follow rules. So nobody wants to, especially in our doctors, we don't want to do illegal things. So many a times we are told, but this is how I was doing it in my country. I tell them, no, but this is not your country. If you drive in Germany at 200 kilometers an hour, you can't drive in Oman at 200. It has to be 120. So, but we need to tell them our rules and regulations for them to work with us. So, and as I asked Rahma many times, you people are very busy. I need to, as a group, to sit down and make me a checklist. So I can then send the checklist to these clinics and tell them, listen, this is the rules and regulations. This is the checklist. Next time we come to audit you, this is what we're going to ask. So many of them correct it. I have had many people with whom we had violations. I don't go with a stick and start punishing them. I send them this violation. I said, listen, we came to your visit. These are the violations we found. Please correct them. And they correct them. Only when we find violations which are affecting patient safety, then we go in and close the clinic for that small amount of time in which they have to do that. So I'm ready to help all of you to regulate and even classify clinics as level 1, 2, and 3, as Rahma had mentioned. But I need guidelines or guidance from your group, you know, to tell me, so then I can do that. Now, inshallah, soon we will have an online, Kul Muassasa will have an online folder with all the technicians, everything. And after that, you can even go online into the clinic and look at their records at limited accessibility, but so next time you don't have to take your car and go into the center itself. You can click on a button and see who's the doctor, what is his qualification, who are the technicians, what are their qualifications, and then if you feel that you need to go and make a visit, you can go and make a visit. So these things are developing. We have the desire and the to do it, but the means, you know, the Ministry of Health, the means are not there. We are not given the means to develop it. Now we are looking at outside the Ministry of Health to give us the technical ability to be able to monitor. So we are ready to help you as long as you help us to help you.
Okay, excellent.
Thank you, Dr. Mazen. Sorry, Mariam, if I can just comment. Really, to be fair with Dr. Mazen and his department, they are always very helpful, very supportive. And I believe that with their support only, we could control so much of the doctors who are treating patients with infertility. We managed to you know, control it and put some of these specifications, and people are becoming more and more aware that not everybody should be treated by a generalist. It has to be only by fertility specialist. But we need to work hard, as he said, and inshallah, I know that inshallah, we can develop these levels soon, and we will submit it to you that the need for these levels, and hopefully we will get the Minister of Health approval for it.
Yeah,
I
sure.
hope
Anytime.
This is a very good spirit. And I think one of the people whom you guys mentioned before, Dr. Maha Al-Khadouri, have posted some of the questions that I didn't see earlier. Dr. Maha is asking, in MOH hospitals, are there technicians doing the IUI sample preparation currently? I don't know, Dr. Rahma, Dr. Muna, running fertility?
No. Well, those are ideal things which I mentioned, ideal things. And that's why I said these rules should be applicable to the Minister of Health as well as to the private institutes. But we have an automated machines, we have an experienced staff who can deal with this. But yes, for example, in Wataya Polyclinic, they have a technician who deal with those, but it's not available in all the Ministry of Health. But the ideal things we have to say, that what things should be done, and then we can correct it.
Okay. Dr. Maha also posted another question. If you categorize centers into levels, a patient will not be able to get timely progress in infertility treatment from ovulation induction to adding IUI, then IVF, which wastes the previous timing, especially for certain cases. Why not set a high standards that fertility treatment should be in a comprehensive fertility ART centers? Yani instead of dividing into levels, each center has to have everything. Yani, or one center have everything.
I thought about that, Mariam, but unfortunately, it's not an easy to get an REI specialist. It's not easy at all. You know, you need already the service for fertility in Oman is very low. And to get an REI specialist for all, it's not an easy thing. And at least if we can help with these patients, to give them somebody who is board certified to treat them and look after them and with an experience in infertility, I'm sure these clinics will go ahead to improve their quality. They will be forced by the community itself. When I go to a clinic, when I know that they are level 1 and I know what is the meaning of level 1, then maybe I will not go to that clinic. I will go to level 2, to level 3, to level 4. That will encourage those clinics to improve their quality of care they are giving. That's what I thought. But at least to start with, if we categorize them in that way, we will come to know how much of fertility clinic, how many, and at least that will guide the public, the patients who are looking for fertility, what they are supposed, where they are should go, and what is the quality of care they are expected to have in that clinic. And then they will know that if it's fine for them to continue with that doctor where they don't have an IUI, for example, and then after that they will change, because that clinic will not provide that service of the IUI, for example, unless they are recertified by the Ministry of Health, So I'm sure this will improve even the quality of care given to the patients and the quality of the clinics going to give the fertility treatment. That's what I'm hoping, yani.
Okay, and I think people are in a hurry to go for dinner, but we'll still take some more questions, of course. Dr. Obma Shankar, thank you, Dr. Rahma, for the informative presentation. In times to come, will the 5-year period for freezing be reconsidered? There are many patients whose gametes are stored for future use, and soon it will go beyond the advised time frame.
I think we already talked about this, and from the ART clinic, and I already submit a proposal to the Minister of Health to get for the approval, and hopefully we are going to get that approval soon. I already met them few months back, but for the time being, when I discussed that issue with Dr. Mazen, we said that for the time being for 5 years frame, but after that they have to contact the couple and find out if they want to continue. I don't think there is an issue with the continuation of that, but they have to know that maybe that will affect their gametes or their embryos. But there is a proposal submitted already to the Minister of Health, and I hope that we will get now people start recovering from the pandemic, and they will try to look into other subjects. But we already submitted that a few months back.
Okay, there is a question that I'm not sure if I understood it correctly, and the participant who wrote the question, maybe if I am not saying it correctly, they can clarify. Dr. Asma Aljerk, if I'm also reading the name correctly, can I understand in my clinic as a specialist, experience 13 years, OB-GYN, I can treat infertility cases by general medication? Because in Al Buraimi, few clinics there and there are no consultant. I think the question is about that she's a specialist. She has 13 years of experience, and there are not many fertility clinics that are equipped with a consultant. Can she treat patients with medications?
Well, we can. I don't know what Dr. Mazen think, but for me, I think if any doctor wants to treat fertility, and if we are going to have the applicable, those levels, then we have to know her certification, her experience, and what sort of, if we can do that in intrauterine insemination or that, then she has to be recertified. And now more and more we are, now I feel this awareness of having a control and regulations by the Minister of Health is widespread now. It's not like before. We're getting now more and more doctors who want to be recertified, who wants to be recognized by the community. And they are already, for example, interviewed, and that sort of facility already applicable. It's there in their clinic. So I'm really happy. I have no problem at all, especially when it comes to the fertility, how to interview these doctors and to give them the certification if they are having the certification.
Okay, there is a question from Dr. Veena Baliwal from Salalah. طبعا Dr. Veena is very well known, one of our colleagues. She is asking how to improve IUI services at regional hospitals, especially in Salalah, as this far for this far from centers, this facility not available neither with us or in private? IUI? How to improve the IUI services in regional hospitals?
Like Mariam, I feel that, in my opinion, if you have the interest, especially if you have a specialist reproductive medicine or a fertility specialist, you will not be happy to treat patients only with the simple medications and gonadotropins. And when you have patients who are having simple male factor or endometriosis, simple, type grade 1 and 2, minimal and mild, for example, and you don't have an IUI service, you will look with the Ministry of Help from the Ministry of Health to improve the service in your department. I think sometimes it's the effort from those who are running those services in the department because if I am the authority and if you don't come with the figures and telling me that my community is suffering from fertility this much, and I do need this type of facility, how would the ministry will know? Although it is worldwide known that the infertility in any community, it's well known to be at least 13% or 15%, okay? That is very much needed. That service very much needed. So sometimes it is the department also, how motivated they are to look how their way to help their population. That is in my opinion.
The ministry to do it.
Yes.
They have to ask them strongly to provide the service because their patients deserve it.
I know the burden of the obstetric population and the need for obstetric help of the obstetric issues is more demand on the Minister of Health rather than the fertility issue. But these populations also need to be helped. I don't know what is every hospital, I don't know what Muna will think, but I think it is sometimes the effort of the doctors themselves.
Dr. Muna?
Rahma.
Yes.
Regarding the IUI service in every hospital, for example, when we started in 2011, the service was not there, but the good thing that we have interested staff as well.
Yes.
So we have sent 2 or I think 3 of our staff attachment in Royal Hospital, and really the staff in Royal Hospital also were very cooperative. So they received the training there, and after that they came back and we launched the service in Abri in 2015, and it was really a great addition to the place and to the governorate. So if you have the interest, you can, but you need to have the urge to continue and passion to do.
Okay, thank you very much. There is a specific question for Dr. Mazen from Dr. Maha. We had 2 patients with triplets.
I saw the question.
Okay.
First of all, Doctora, concerning the first lady from Buremi, as Dr. Rahma had mentioned, those who wish to certify themselves as a specialist in fertility, we have something called additional privileges in your, if an obstetrician or an obs and gynae person wants additional privileges, they can always apply for these privileges, and then we can set up a small interview, and then we can, if they are up to it, we give them the privilege and they can put it there. And if they're not up to it, we tell them what are the gaps, and they can then fulfill the gap. And the second part is if any private facility wants to add services, they should let us know first before they start their services themselves without telling us. That is not considered to be correct. So like some if you want to start an IUI service, let us know. We will come and examine, because in one case which we were not very happy was an IUI service was being done, and we found that that lady was not labeling the samples. Now that's very dangerous. The sperms could be mixed up, and you will have a dangerous situation, legal situation. The doctor told me, we only do one sample at a time, but that does not mean you do not label things properly. Things have to be done properly. Accidents are what they are. Accidents can happen without people's knowledge. Nobody does these things with knowledge. So we can give the privilege of anything they want to do if done properly, and we come and inspect and make sure that the things are in order, and we then give them the privilege to do either a procedure or the privilege to prescribe fertility. As far as Dr. Maha is concerned, I cannot be there. I mean, we have 1,890 private health centers. I'm sure many things happen there. So even if I have 1,900 people sitting in each clinic, I cannot even then check what's happening there. So there is a proper system of reporting. Send us an official report saying that this is what's happening. This is not considered to be correct. And we will go there and investigate, and then give the report to the people who are you people. And if you tell us that this is incompetence, we can do the further legal actions. But let me tell all of you, we are a legal, law-abiding country. I cannot just go and close a clinic. I will be taken to court. In fact, I'm being taken to court every day. So we have to do things in a proper manner so that we win in the court, and we win usually because we do things properly, legally, through proper channels. It might take a bit longer, but as I said, if we find that things are being done in a way which is detrimental to patient safety, we have the legal framework of closing that place instantly. But it has to be done through a proper channel. You have a problem, I get complaints from all of from doctors from Royal A&E, doctors from from those who are doing other, that this clinic or this hospital sent us a patient without proper this, and we take action. So I need to know. We can go and do a proper audit, and if the thing needs further legal action, we give them warning, or we can stop them, we can do other things. But I need to have things done in a legal framework. Let me just say that. I know many of you are very enthusiastic and get a bit annoyed with such practices, but things has to be done in a proper manner for us to. Otherwise, we take them to court. They take us to court and say that you closed my clinic. It cost me 50,000 riyals, so I need compensation. If we do it properly, they know immediately that we do things properly. So this is my answer to all of you, not just to Dr. Maha, that if you find any illegal practice, let us know, and in an official manner. Even an email or WhatsApp is official to me, with the name and the correct credential, that this was the clinic, this was the name, this was the patient's name, so that we can then go and check the record.
Right.
Is that answer your question? Yeah.
I think, Dr. Mazen, you are very, I absolutely know that you are very cooperative. You are really taking whatever messages we are sending to you and emails very seriously, and you go and dig into things. But I encourage my colleagues from tonight, that as Dr. Mazen says, we cannot do things just because I don't like somebody. We have to have legal.
I didn't say about not liking.
Yeah, I know that. But I mean, if you have any issue, and that's why I always encourage my colleagues, if you have you think that there's things which is happening not in a proper way, you just go and complain about it, keeping it only in your heart, or you're just talking about it with your colleague, that not solve the issue.
Sure.
And Rahma, I'm saying it's not. I'm not asking for an official typed letter from your Tariq Barwa. Even an email or a SMS or WhatsApp with your name and the the institution's name and the patient's name, and I will take action. I just
agree
need,
with that. I really, I did that before.
If
and
I
it
get
was
a
happening
message,
that
if
way.
I get message that somebody somewhere is doing something, I will do something, but I don't tell you what I did.
Great. Thank you very much, all. I really appreciate such open heart and the سياسة الباب المفتوح, open door policy of Dr. Mazen, and him being patient and sharing some of his valuable time with us tonight. Thank you very much, Dr. Mazen. And I
Most welcome.
would like to close this webinar for now. It is like almost 9:30 and people are hungry. I think their families are waiting for them for dinner, including my mother is waiting for me. But I really would like to say that today's webinar is an opening. It's only to open a door for discussion. It is not the end of the discussion, because I can see the question answer box and the chat box are all full of comments and suggestions from Dr. Naama, lots of other colleagues from the fertility field, from the private health institutions, and from the Ministry of Health hospitals. I think this is a time where the fertility services in Oman from both sides should come to a discussion and opening hot subject. And I hope Oman Fertility and Gynae Endoscopy Group is a forum where both government, NGOs and private health institutions can sit and discuss things. And it seems we actually have already some open channels for such. So I would really thank all those participants who have been with us tonight, those who shared lots of their thoughts and their time. I would like, of course, thank all of our speakers whom we are honored to have tonight, Dr. Mazen Al-Khabouri, Dr. Rahma Al-Ghabshi, Dr. Francisco Riaz, Dr. Saeed Al-Kindi, and Dr. Muna Al-Badi. And I hope we come out of this webinar with lots of aspirations that inshallah ta'ala fertility services in Oman will go for the better, and inshallah ta'ala we will continue this dialogue inshallah on many different levels. And thank you very much all for tonight's time.
Thank you very much.
Thank you very much. Thank you for being with us.
Thank you.
شكرا جزيلا.